am Dr. Aronson Ramos. Can everybody hear me okay without the mic? I'll try not to whip my head around too much, but I like to sort of look at the slides as I talk, so I'll do my best. I am a developmental and behavioral pediatrician in private practice in Coconut Creek. And my part of the survival tour today is to talk about pharmacology and medications. I do want to thank, first of all, Unicorn for giving us this opportunity to share information, and all of you for coming, because by coming, you're trying to become more informed, better advocates for your children or your students. I'm assuming that most of you here are parents. Can I just see a raise of hands? Just about everybody's a parent. How about clinicians like teachers or therapists? Okay. And physicians? Oh, okay. We have a few. One clueless pharmacist. Okay. Oh, parent. Okay. All right. And you can cross boundaries. You know, you can be a parent and a physician. You can be a pharmacist and a parent. So we know all of this. So what I want to emphasize, what I'm going to talk to you about today is not lists of medications and their side effects. I feel like those are things that you can look up on your own, and we have all of that information, really almost too much information available to us in that regard. What I want to talk to you about is really an approach. And obviously it's going to be my approach, but I'm also going to try to incorporate other physicians and their specialties and the approaches they might take in using medication with your children. You know, psychopharmacology is very unique because the end point is different. It's not like treating a pneumonia or treating a cellulitis or treating cancer. It's much different. We're going for an improvement in things that sometimes can be difficult to measure. So really I'm going to give you the overview today on how to make that process successful. And I encourage questions. I don't mind being interrupted. I think if you have a question, probably somebody else in the audience does as well and would benefit from your question. So, and I'm not going to talk about alternatives to medication. That's not my topic. So there may be you might have burning ideas or comments. I'm happy to stay after and talk to you about it. But the purpose today is not to discuss the alternatives to medication. We know they're all out there. But really we're going to stick to traditional medicines. Okay. I don't know why my text isn't showing up, but it's not. Okay. We're going to get beyond technical problems. It was really, on this slide, were really a list of questions, and I don't know why they're not showing up here. But, no, that's not even the right slide. Oh, my goodness. Okay, skipping around slides. We're going to make the most of it, so I'm not wedded to my slides. That actually is not the next slide. The next slide. But what was on this slide were a series of questions. And really, it's about how we decide. You know what? Let me get my computer so I have my PowerPoint on it so I can be looking at that as we talk. That's okay. And I have a whole area where we're going to cover that. But I will say while we're getting everything ready that we have so many options now. We have patches. We have sprinkle capsules. We have powders that can be dissolved in liquid. We have so many different methods now that now more than any other time, compliance and getting children to take medication is a much easier task than it used to be, just because of the sheer number of options we have. Okay, let's get this going. And I have very pretty pictures. Go ahead. Okay, great question. He asked, what is a developmental pediatrician? Developmental behavioral pediatrics is a subspecialty of general pediatrics, just like a pediatric cardiologist, endocrinologist, pulmonologist, etc. So it's a subspecialty. So generally speaking, developmental behavioral pediatricians, including myself, don't do any routine general pediatric care. They just specialize in children and adolescents with developmental behavioral issues. They can be simple, but not being adequately addressed by your pediatrician, such as maybe not sleeping through the night or bedwetting, or they can be more complex, autistic spectrum disorders, obsessive compulsive disorder, ADHD, and so forth. So we overlap a lot with what child psychiatrists do and what pediatric neurologists do. We're sort of it's that triangle. All three of us are generally seeing, for the most part, the same populations of patients. It's a really good question because every clinician has their referral bias, every one of us. There's nobody who just sees everything from every point of view. It's impossible. So developmental pediatricians come from the field of general pediatrics first. So we have that very strong background in development, in some of the medical issues unique to children, and also the whole gamut of typical behaviors, which are huge. You know, things can look very atypical, and they can still be within the range of typical.
You become the primary provider for people with severe or significant developmental?
Can be, depends on the patient, depends on the case, but can be. So developmental behavioral pediatricians might be diagnosing, might be medicating, might be setting up treatment plans. Sometimes we're working together with, let's see, what's in our PowerPoints? Yeah, okay, and it's this one. Oh, you see me. Yeah, I lost my train of thought there, but.
Is there an age limit different from your practice than there would be on a conventional pediatrician's practice?
Great question. God, these are like setups. You know, it's really interesting because general pediatricians, some will go to 16, some will go to 18, most will go to 21. I actually now go to 29 because I follow a lot of young adults with Asperger's and other developmental disabilities. So developmentally, their age is much younger, and it's much harder for them to make that transition. When they're starting to have more adult medical problems, come on up, come on up. So yeah, that was a great question. Let me just tell you something else about me and computers. This is me. I have a force field that extends around me, and if it's something electronic or computer-based, it's not going to work if I'm here. So. But they are great slides if we can get them to work. Sure. Yeah.
But when she takes certain generic drugs, she does not do well at all, and she actually has issues. We go back to the brand, then we have no issues. So the question I have is, parents that are out there that are trying these medications, how can they be sure that the medication is a good fit if it's the wrong type of...
I'll tell you, as healthcare changes in this country, you have fewer choices, guys. So I might prescribe a medication, and I get a notice back from the pharmacy that it is not covered. And what your insurance company's formulary is choosing to substitute, I would not pick. And we are stuck. So some of these medications can be $400 a month. They are expensive. So when it comes to generics, what we know data-wise is there can be differences in potency, and there cannot be. So it's okay. Oh, it's okay. Thank you. It's okay. Not only mess it up, I just press the arrow buttons now, right? Raphael. I did. Aren't I just using these now? Oh, wait. I went too far.
Okay.
There we go. There we are. There we are. Okay.
Do it again?
Okay. Scare me. Okay, we're good.
No, it's not
Oh. So it's okay to trial generics and see. You know, it's difficult because theoretically it's the same medication. There can be differences in potency, though, and some of it is more anecdotal than research-based. Like, we don't have great data to show that generics are inferior. They can be the same, but, you know, these medicines are expensive, and that's... I'm going to start going through my arrows. You're set now?
Try it.
Prove it. Okay. All right, we did it. Thank you. Thank you very much. Okay. So we covered actually a few things here. So when we begin the process of deciding, that's in many ways a unique process for different clinicians based on some of the things I just mentioned with referral bias and what different physicians' backgrounds are. But also, we have more standardized things. We have an evidence base. We have practice parameters. We have accepted standard of care and things that drive what medications we decide to use and how we use them. But also, we can't forget the practical issues, some of which you were bringing up, which include insurances, formularies, how are we getting that medication into the child, the child's age, the family history and the medical history. Yes?
Whether or not medication is appropriate in the first place.
Right. I mean, that's obvious. That's obvious. Sure. Absolutely. I mean,
Get left out though sometimes.
yeah, sure. And we'll discuss a little more about that topic as we go on. But as I mentioned today, my goal, that's why people are here, to hear about medications. So we are going to, for the sake of argument, discuss their use, even though there are plenty of situations where there may be alternatives to medication, absolutely. We're going to go over what the medications are, the main ones used for behavioral and emotional problems in children, and those generally being the stimulants, the SSRIs, mood stabilizers, atypical antipsychotics, and there are some unique classes of medications as well. Dosage we're going to talk about, and there's a really important principle with dosage, and that's the axiom we use, start low and go slow. And that makes sense intuitively to most parents, and it makes sense intuitively to most physicians. But it's a very important principle, and it's an important thing to remember when you're hesitant about starting a medication, that generally that's going to be our jumping off point, that we're going to start at a low dose and progress slowly. Classes of medications we're going to talk about, and just so you have a broader understanding of psychopharmacology, a class of medication it can be determined by the chemical structure of the compound, it can be determined by its pharmacological action, or the class can be also determined by what we call the therapeutic indication. So that's usually the FDA approved indication for use of that medicine. Monitoring, if you don't know what you're monitoring when you start, we're going to have lots of trouble, both physician and parent. So it's important, that's a really important question that we're clear on when we start. And then we're going to walk through the process of how we decide. So I'm going to give you a really brief history on what pharmacology is, the study of drugs, their sources, their nature, and their properties, and the body's reaction. It's interesting because the first pharmacologist in the United States was a man named Jacob Abel, and he was not an MD. He was a pharmacologist. A pharmacologist is a PhD in pharmacology. People get confused because they say, I need to find a psychopharmacologist. Well, every doctor who prescribes psychopharmacological medication is a psychopharmacologist. Now, there may be clinicians with extra training, extra fellowship training, professional memberships, and so forth that provide them with additional credentials to prescribe. But it's important you understand that distinction. We talked a little bit about professional training. The point of that bullet there was to mention the different referral biases and different sort of content that physicians bring to when they prescribe. Practice parameters. So we all belong to different professional organizations that help guide us, whether it's the American Academy of Pediatrics, the American Academy of Child and Adolescent Psychiatrists, or the American Academy of Neurologists. And these organizations are constantly looking at all the data, all the evidence, and best practice in helping to guide clinicians as to how they should be using these medications. Research every week. I mean, you think it's hard to keep up as parents. It's really hard to keep up as a clinician. So, for example, Lexapro, which some of you may know, it's a selective serotonin reuptake inhibitor. It was recently FDA approved for use for depression in adolescents. So it's really important that the clinician you pick and you use and you work with stays current on the research because it's constantly changing. On the converse side, Celexa, which is also an SSRI, was shown in a very large study not to be very efficacious in autistic spectrum disorders. Now, the trap is you take one study and you go, oh, I'm going to change everything I do. Obviously, we don't, but it's important we use the research to keep current and keep active. Clinical experience, that's the own clinician's professional judgment. So when I always prescribe X, this always happens. That's what we have been taught and what we learned from our own prescribing practices, and that's very important as well. And then the pharmaceutical industry, which we may all have some mixed feelings about, but nonetheless, we rely upon them, right? I mean, we rely upon the pharmaceutical industry to bring to market medications that give us options. And, okay, that's the thing I'm going to say on that. We sort of covered that already. So in terms of what medications we're going to use, let's talk about the different ones right now. And I encourage you, no questions too small. If you have it, somebody else probably does too. But the main medicines we're talking about for the population we're considering here today are what we call the stimulants, the anti-anxiety and antidepressant medications, which now pretty much are all what we call the SSRIs, or selective serotonin reuptake inhibitors. I am not going to discuss the tricyclic antidepressants. If you have a person out there on it, don't freak out. They're still used, but really not very commonly used in kids because they've been replaced by the SSRIs because of their safety profile. They're much safer and easier to use. The old tricyclics, you could have arrhythmias and you needed to have EKG monitoring. So when the SSRIs came along, they've really gone out of favor. We're also going to talk about the atypical antipsychotics, a group called the adrenergic agonists, mood stabilizers, the anti-epileptics. I'm not going to cover lithium today, and I'm not going to cover the benzodiazepine, which is Xanax and its cousins, because those are not indicated in children. How do we decide? Well, I've mentioned, and I'm sorry, I'm going to have one boring point that's going to echo in your head, which is that deciding is a process. And the best way it's done is when parents, patients, and clinicians are partners. And we all have a job to play in that process. But for me, it's not, yeah, you take this, we're done. No questions asked. That's not my approach. And in this area of psychopharm, maybe if you're doing a chemotherapeutic regimen for treating lung cancer, that's the way it goes. We're limited. But not in this area. And some of you out here that are my families know I'm open. And it's important to be open. Doesn't mean you call it the shots, but it means we work on this process together. I may be the expert in medications. You're the experts in your children. You're the ones who are observing the behaviors and the changes that we're guiding our practice based upon. Monitoring, what are we monitoring? Monitoring is active. We don't write the prescription and say, okay, see you in 3 months, we're done. If that's the way it's working with these sensitive issues, it can be very difficult. So we want to be sure that we don't prescribe and forget, and that you are playing an active role. That you are watching, you're listening to teachers, you're listening to therapists, you're observing their friendships, and you're sure to get us the information. What are our expectations is critically important. Sometimes we do what's called a blinded trial, where we really ask, you don't tell anybody else. Maybe dad knows, but teachers don't know.
Double-blinded usually.
Sometimes, not always, with parents, because I'm writing the prescription so they know they're getting a medication. In research, yes. In research, the gold standard is what we call double-blind, placebo-controlled trial. But here, we want some unbiased opinion from onlookers, so it's not forever. There's a point in time where ethically we need to inform everyone if a child's on medication. But we may want certain points of time where we want blinded information. And then in terms of working together, I already pretty much stressed that point, but we need a team approach. Absolutely. We're going to get into that in a little bit. Here's another very important sort of overall point. We're looking at symptom relief, not cure, with these medications. So psychotherapeutic medications at their best improve symptoms so that quality of life and functioning are better. And we're not necessarily, our endpoint is not necessarily, like I mentioned earlier, the endpoint is different. It is not treatment of the infection. It's how much improvement of symptoms is enough improvement of symptoms. Of course, weighing that with when we get side effects. So it may be we get up to a certain point, that's as far as we can go with that particular medication. That's the best symptom relief we can get. And if we go higher, we may get symptom relief at the expense of side effects. This is also where the idea of target symptoms is very, very important, and I'm going to get back to that in a second. Right here, target symptoms. When we prescribe, we're looking at target symptoms. We're not looking at diagnoses per se so much as what the symptoms are we're treating. So let me be clear on that. When somebody comes in and they say, you need to help me, I have to treat my child's depression, I'd rather know what the symptoms are. They're isolating, they're unhappy, they're thinking morbid thoughts, they're eating too little or too much. These are the key descriptors that help us pick which medication we're going to use, more than just the overarching diagnosis.
This is a problem that I've had with my wife several times. I'm a physician too.
Mm-hmm.
And sometimes she's read something or other in wherever, and she tells me, oh, but my daughter is having hallucination, one or another symptom, and I understand, or the doctor that's seeing the kid understands a complete different definition of what the patient is having than what the parent is actually trying to tell. You get this?
Well, that's where the translation and the communication comes in. When we're seeing something, we may label it differently, but we should be able to agree on what we're seeing. And that's where good description comes in. And this is really the key to this point about target symptoms, that we want to know, is it the aggression? Is it the impulsivity? Is it the hyperactivity? What are the behaviors? What are the things you're seeing, right? Because that's more informative than my child has ADHD. Are they an inattentive daydreamer? Or are they a hyperactive, impulsive, motoring child? Are they more aggressive? You know, are they outgoing? Or are they internalizing? Because these are the little nuances that allow us as clinicians to be more successful. When we talk about comorbidities, that's a fancy medical term for just coexisting conditions. And that's very important because if your child has ADHD and they have tics, and the tics are really significant, that's going to affect how I prescribe. Or if your child has ADHD and is very anxious, that's going to affect what I prescribe. So coexisting conditions do influence to a very large degree the things physicians use to pick out to use. Family history and the own child's past medical history are very important. There's a strong family history of bipolar disorder and mania. We're going to be real careful with those SSRIs, or a family history of Tourette's, or depression, or anxiety disorder. These things are very important. It can be in the parent, it can be in the grandparent, aunt, uncle, the close, really first and second degree relatives. Also, the medical history of the child is important. If your child had a congenital heart disease, that child has a very specific monitoring protocol required if they're trialing stimulant medication for ADHD, for example. Modes of administration, if you can't get it in them, it doesn't matter. So Concerta, for example, which is one of our stimulant medications, it can't be cut. You can't do anything with it. It's bigger than a Tic Tac. If you can't swallow it, you can't take it. So that is, you know, I mentioned earlier, thanks to someone's question, that we have sprinkle capsules now that you can open and sprinkle on a teaspoon of medication. We have powders that you can dissolve. We have patches. We have depot or long-acting forms of administration where you have to give it once a week, or injections. So all of these things matter because that's also, you know, if you come in and you don't share that, oh, my child is really tough with these things, or don't anticipate how tough it's going to be, it can make it more difficult. And the last thing is we need to know what baseline behaviors are before we start. So going back to ADHD medication, if we use a stimulant, which we know a side effect is decreased appetite and difficulty falling asleep, and that child comes to you with a history of it always takes them 2 hours to fall asleep at night. We need to know that from the start so that we can judge what their baseline behaviors are and how that meshes with the side effect profile. So hammering this point home, this theory versus practice, you know, if you can't take the med, it's not going to work, and we have to be willing to modify our plans. Sometimes we have to be very, very creative. Daytrana, have you heard of Daytrana? It's a patch. It is a stimulant medication. It's a form of methylphenidate, which is the ingredient in Ritalin, and it comes in a patch that you apply and can remove. Typically, it's placed on the hip. Well, I have a little boy who was like, we went through 10, 15 medications. We put it in the middle of his back while he was sleeping. That was the only way we could get him to take medication. Also, cookie dough, yeah?
My son's been on Daytrana since his
Okay. Let's talk about a couple of these points here for a minute because I think they're worth pursuing. Number one is the patch delivery system is novel, so maybe it's inconsistent in the amount of drug being delivered. We do know with Daytrana that there can be a delayed response, and sometimes it can be 3 to 4 hours before the medication is evident in the child's body. So we know, and sometimes we have to give children morning boosters for it. Medicines don't work for everybody. I mean, if it's not working, I don't stick with it. We're moving on. ADHD medications in general, first of all, the diagnosis technically by the books, can't be made till age 6. Every ADHD medication that's FDA approved is only FDA approved down to age 6 except for Adderall. So that's just what we know in terms of the research. Now, we're going to talk a little bit about off-label use of medications because we do it all the time and sometimes with great success. But what I would say is here's a perfect opportunity for dialogue. Speak up sometimes. Well, if they can't listen, I don't know. You'll have to figure out what to do. But we need, we need listeners. Now, it doesn't mean that every suggestion you have is the best suggestion, but sticking with the medication beyond the point where people are seeing benefit is counterintuitive, I think, to all of us. We have trade-offs. If you get a child who's a perfect soldier and sits in class and his teacher is really happy, but you lost that spark in his personality and there's something missing, well, maybe we want an intermediate duration of action medication where the bulk of his learning, he's a little more zoned and focused, but then by recess and afternoon and lunch, it's wearing off, so his social interactions are more appropriate. There's no perfect medication. And so we need to weigh all of these observations and the benefits for each. One other point I wanted to make under theory meets practice is this idea of 1 + 1 is 3. And that's something we use that. It's another axiom we use sometimes in pharmacology where sometimes combining 2 medications gives you much more benefit than either one alone. And we don't want to get into the trap of polypharmacy where we're using loads and loads of medication and we can't distinguish the effects of each one. But that's another thing we need to keep in mind. Mm-hmm. Absolutely. Yes. Oh, cookie dough. Cookie dough is a way to get medication in. So you buy the cookie dough. Buy the cookie dough and you shove whatever it is they got to take inside that cookie dough. That stuff is so sweet that generally in peppermint patties too, you can sometimes get pills that can't be sprinkled or given another way. Sometimes we can get it in that way.
Is there any ADHD medicine that they have an appetite with?
Yes. Let's move on to those slides. This is one of my other pretty slides where we're going to reflect and talk about we need a map for the journey. And the point of this is, elephants, they know how to get there, but we need to know where we're going. We need to define what we're trying to achieve with our medications to be able to get there successfully. And then we'll talk a little more about the specific medications. Yeah, it's a great question. Yeah, well, you need to see the patient you're prescribing, of course, but if a parent tells me they're on Prozac and that medication worked great for them, and they tried all of these other SSRIs, they tried Zoloft and they tried Luvox and they tried Lexapro and had side effects, and let's say we're treating their child for OCD, got to start somewhere. That's a reasonable starting point. So I do take that into consideration, and that would go for parents, and it would go for siblings, and all first-degree relatives. So let's talk a little more, because I know you guys are dying to hear about the specific medications. So let's talk about them for a minute. And I don't want to spend an inordinate amount of time on it, because once again, I want to get to the process and the big picture ideas, because you may look these things up, and Hippocrates.com is a great website. And also at the end, I'm going to give you my website, which has links to some good pharmacology websites. Okay, Cochrane Library. You can get it from him. But yeah, that's a good listing as well. So when we talk about the stimulants, we're talking about really 2 classes of medication. Those are the methylphenidates. Methylphenidate is Ritalin, and that's Concerta, Metadate, Ritalin LA, Daytrana, Methylin, Metadate, and Focalin. Those are all in the same general family. Now, Focalin and Focalin XR differ from the others in the methylphenidate family because they're an isomer. They're what's called dexmethylphenidate. So the original thinking was the side effect profile might be better, which some clinicians have found to be the case, less of an effect on sleep and less of an effect on appetite. All the stimulants will affect sleep and appetite to some degree. So we have the methylphenidates. So people say, well, my child doesn't take Ritalin, he takes Concerta. I mean, Ritalin just got a, you know, it's like a dirty name. It's like Prozac now. I don't take Prozac, I take fluoxetine. Whatever makes you happy, but Concerta is Ritalin in a new formulation. The way all the medicines in this family of methylphenidates differ from each other is delivery. And the delivery can be markedly different. So you could take, for example, Metadate and do beautifully, and take Focalin and do horribly. And that's been well documented. So when your physician is, and Datron is in that family too. I left Datron out. When your physician is moving around between medications in the same family, there is a logic to that, and there's a reason. They should be able to articulate that to you, but it's because the method of delivery does affect the response. So we have the methylphenidates in the stimulants, and then we have the we have the amphetamines, which is Adderall, Dexedrine, Vyvanse, Adderall XR and plain Adderall, okay? And those also, all the methylphenidates, all the dextroamphetamines affect sleep and appetite. They can worsen tics if you have them. They can bring out tics occasionally if you don't. They may make you more anxious. These are all known side effects.
What's your opinion about THC and its effects on ADHD?
You're talking about marijuana? Just don't want to, I mean, somebody came in the other day and he told me he took 2CE, which is, do you know what that is? That's LSD in a new form. But children, teens, I see, self-medicate with marijuana. So if we're doing a good job with our meds, they shouldn't have to use it. So that's the buy-in I try to get with my teenagers. I try to get them to be really honest with me, tell me if they're smoking or what they're doing, because if they don't tell me, you know. But it's not indicated to mix them. No, not a good thing.
Well, in high school, my son decided to date Mary Jane instead of, you know.
Very common.
He made that, he's now in the Army, he's doing really well. But in general, I read some very interesting studies that the use of marijuana instead of psychotropic drugs.
Okay, well, I don't have, you know, once again, going back to my friend here who's going to tell us about double-blind placebo-controlled trials, you have to be careful about evidence and where you get it from. So I've read studies, let's say, on hyperbaric oxygen therapy in the Journal of Medical Hypotheses. Well, thank you. No. But, you know, that's a very peripheral, marginal journal with not a rigorous editorial board and not a process of peer review. So study doesn't equal study, but let's just suffice it to say that combining illicit meds with prescribed meds, never a good idea. Teens do, and I do get them. I really try to get them to talk to me. And there is doctor-patient confidentiality. If they're not going to hurt themselves or anybody else, if they're not honest with me, just like my friend who took 2CE, if he hadn't told me about that and I hadn't looked it up, like I would really have been in the dark on what this child was experiencing. So I think it's important with our teenagers that I say to them, give me a chance. Don't smoke pot for 2 weeks. Give me a chance, because if you smoke pot while I'm trying to titrate your medication, I can't do a good job.
What is the fear or the problem with our kids getting addicted, you know, in the teen years and really using medication?
Yeah, these medicines are not addictive, and that's one of the things that I have like on my post-test today. They don't have addictive properties. So, you know, it's important we don't use them psychologically to make us addicted, that, oh, I didn't take my pill today, so I couldn't do well on my test. You know, the long-range goal, I tell all my patients that, you know, I tell a lot of them, you know, someday you might not need me anymore, and that's not always a bad thing. But there are people who are going to need medications for the better part of their life to function better. So medicine is a tool, one of many. Like, that's where I can actually sing the praises of developmental behavioral pediatricians, because we have many tools. We don't just have medications at our disposal. I want to allow you to.
When we talk about other things, especially adolescents taking along with their meds, the psychomotor stimulants and the SSRIs, a big problem that I've seen is
Absolutely. Thank you. Yep. Yeah, absolutely. I tell them, look, you want to gamble? You want to gamble with your life? You know, we get down to it because you could precipitate an arrhythmia. I mean, there's sugary, energy, Monster, all these drinks, absolutely Red Bull, and they're using them as drugs. So once again, it's generally self-medicating. So I try to get that buy-in, you know, and I say, look, give me time. Let me make it work. If you're using all this stuff, your mom's wasting her money today, we might as well just stop right now. And I really try to get them to give me that chance. So we'll take one more, then we'll go on. Can we go back to that just so we can remind me? So we can get through this list real quick, because I know some of you want to know about the different families of medications. So the stimulants we just talked about. The non-stimulants include atomoxetine, which is Strattera, standalone, by itself, ADHD treatment that must be taken really 3 to 4 weeks to even see a benefit with. That does not affect sleep and appetite, and it does not worsen tics. So there are some nice effects from Strattera. And another non-stimulant, I'm going to talk about the alpha agonists for a minute, because you're going to hear a lot about them in 2 weeks. Alpha agonists are generally 10X and clonidine, which are off-label use for ADHD. 10X is being reformulated as Intuniv. There'll probably be television commercials, you know, when a new drug hits the market. It's supposed to be released in November. These medications are, Intuniv has the FDA indication for ADHD, and it is a non-stimulant. So the side effect profile is different. It does not affect appetite. It does not worsen tics. It's actually a medication we use sometimes to treat tics. And it does not worsen anxiety. It has its own set of side effects, but it's another tool at our disposal medication-wise.
Is there any long-term studies on what these medications do to the heart?
Long-term. I mean, almost every medication you've ever consumed in your life doesn't have long-term. Because yeah, well, the American Heart Association came out with a recommendation last February that any adult or child on stimulant medication should have a baseline EKG. And guess what happened? Like, the medical community freaked out because that was like millions of kids. So they backpedaled and said, well, only if there's a family history of cardiac problems or heart disease. But it's certainly at your prerogative, and I encourage all my patients to do it. For 10X and clonidine, yes, it's indicated to have an EKG. As a baseline. Now remember, an EKG is not a perfect test. You're capturing one moment in time. It's not a Holter monitor. You're not going to catch every possible conceivable arrhythmia that a child may have. And if a child has a history of a congenital heart disease or a strong family history of something called Wolff-Parkinson-White or an arrhythmia, that child needs a full cardiac workup.
What would you say the...
Didn't move on? Move on? Okay. Yeah, we'll talk about that too, because you need to be careful when you get to a medication to treat the side effects of a medication. Not my favorite thing. Sometimes it's a must, but in that situation, not the greatest. And clonidine, I don't like, and I'll raise my hand and tell you I don't use it, because if you overdose on clonidine, you got big problems, big lethal problems. So I don't like it in houses with small kids. I'm going to run through because I got like 13 minutes left, so we'll buzz through kind of some of the other slides so we can get to the main points. But the SSRIs I mentioned to you already. We're talking generally Prozac, Zoloft, Luvox, Lexapro, Celexa in kids. Effexor, Cymbalta, Remeron, some of the more atypical antidepressants have no pediatric indication, have no data. Doesn't mean they're not used. They are, and sometimes quite successfully. But they're not the typical first-line medications you'll use. The atypical antipsychotics I want to talk about for a minute, because they're important and they're being used a lot now. And that's generally in kids, Risperdal and Abilify. We have Geodon, Seroquel, and Zyprexa as well, which have zero data in kids. Once again, doesn't mean they're not used. Risperdal has the FDA indication for use in autism for self-injurious. I'm going to make you hold it till the end, okay? For self-injurious behaviors. So it's a medication for autism. It doesn't treat the core symptoms of autism. It treats the secondary problems, which are sometimes the aggression and the difficult behaviors. Abilify and Risperdal, big problem is weight gain. You're like a vacuum cleaner in your stomach. Kids can gain a lot of weight and be at risk for diabetes and other metabolic problems. So that's why we have to be very careful with Risperdal. Used in little doses, less problems, big doses, bigger problems, and also movement disorders, tics, and something called tardive dyskinesia, which is rare, but if you get it, it's a big, big, big problem. Abilify is a cousin to Risperdal. You're going to hear more about that because that has been researched as an alternative to Risperdal for use in autism, and I believe it will get the indication, and there's less weight gain with Abilify. When we get into the mood stabilizers, here's a territory that's really tricky, and we're talking about Depakote, Lamictal, Trileptal, Neurontin, these medications, much less data. It's almost all extrapolation from adult data, and they're often used for bipolar disorder and behavior, severe aggressive behavior problems, but data is significantly lacking there. I'm going to skip that slide. Skip that one too, because, well, you know, the basics of how a drug acts. We'll go through this really quickly. So, I mean, when you're using a medication, what are you specifically doing? Well, that medication is binding to a particular site on the cell membrane, which then is causing the action you're looking for. And agonists is a general term that refers to medications that produce the drug action, and antagonists block the drug action. And sometimes you do want to block the drug action. So when we talk about all these meds, what are we talking about? We're manipulating what are called the monoamine transmitters in the brain. When you talk about all the ADHD medications, you're manipulating dopamine, which is a normal chemical. And this is how I talk to kids and teenagers. I don't want that foreign thing in my body. I don't want to take a drug. All you're doing is you're enhancing and changing normal neurochemistry. So you're working on dopamine, you're working on norepinephrine, you're working on serotonin, and other neurotransmitters to greater or lesser degrees. So every medication can have its intended effects along with side effects. And obviously with side effects, as I've been mentioning, we manage them. We do different things to manage them: sleep hygiene, timing of the dosage, relaxation strategies if the medication is making them anxious. We use things to help manage those side effects. Now, obviously, toxicity is a problem. Lamictal, if you get Stevens-Johnson's rash from it, you can die. Valproic acid, if you happen to be the one that gets fulminant liver failure, you got a big problem. So in medicine, we say first do no harm. You know, we need to be very careful when we pull out some of these more tricky medications that it's not, we've given it serious thought. You've given it thoughts as parents, and your clinician has given it a serious thought because we can't predict. The purpose of this slide was, are we becoming a pillhead society, was my, and there are some important points I want to mention about this. Let me just catch up with my notes here. Here's a few things I really want you guys to ponder. Some people who are really anti-ADHD, like that's a political issue. I mean, everything in this country is now a political issue. So psychopharmacology is a big political issue. And there are individuals who don't believe it's like made up, like it doesn't exist as a disorder. We're not going to go into that, but ADHD medications can be used as performance-enhancing drugs. Absolutely. College campuses, what do they love? Anybody know? Adderall. Adderall. You got a term paper to write? You want to stay up all night? Take your roommate's Adderall. I'm not advocating that. That's what happens. It's also a favorite amongst eating disordered women. So, you know, we need to be careful about that. Social anxiety disorder. Is that really a disorder? Or is that a trait that we've now made into a disorder? I mean, we could debate these things, but the DSM, the Diagnostic and Statistical Manual of Diagnoses, it gets longer and longer. Internet addiction is going to be a disorder. Pornography addiction. No, I'm not kidding. So we're tongue-in-cheek a little bit here, but really we need to think about how disordering we are of symptoms and how much of these things are traits. And for my friend here, where might we enable the use of other tools and strategies? Getting back to the tool question, exercise, joining the Boy Scouts, the Girl Scouts, volunteering, going on walks, going camping, getting exposed to nature, taking a karate class. You know, there are ways, things we can employ, tools we can employ that aren't always based on medication. And the last thing I want to mention with this particular slide is this goodness of fit idea. Some kids are born into the wrong family. really. You're like, where did this one come from, you know? And the same thing goes with schools. And I have kids who come to me, and if they were in a different school, we might have a different set of symptoms that we're dealing with. So we need to, sometimes you're stuck and you can't manipulate these things, but we need to be sure that we're changing and manipulating and being able to use all the things at our disposal. Did you have a question?
Yeah, here's my quandary. My son's been on a cocktail for years, and it's worked. And it's had, up and down. When we took him to San Marino Center, a neurologist down there, said, well, let's just try to wean him off this one. And one was doing mention that to get that actor off. And he became almost suicidal. He was begging us.
Mm-hmm. I think, you know what? But that's a great, he needs it. Because if you have a dead child, you have no child. So it's a really clear example of, these are not evil molecules that we must try to always eliminate and not use. No, there are helpers, there are friends. We need to do it safely. So it was what you just did, and Raphael, just cut me off when you need me to finish. But we do something called discontinuation trials, and they are so valuable. That may be a time where we wean a child off a medication to know what utility did it really have. And sometimes we get confused. We get to a point where we don't know what's causing what anymore. And if you have to go back on it, you go back on it. There are people that are going to be on Risperdal for decades. But if he, it can be done safely. He needs to have monitoring. He needs to have blood work. He needs to have glucose, lipids checked. You need to watch his weight. He needs to have somebody observing his movements and running movement scales on him. So we do it safely. But there are times, and that's a great, thank you for sharing that point, but where a medication is a matter of that child's functioning and surviving. There's a really important point I want to be sure I get to. It's not on this slide, but before we end. And that's my request to parents on how to be a good historian. So let's say you're coming into my office for a 30-minute medication follow-up visit, which is pretty routine. There's information I need to know. And if we start going off on, well, I got a note home today, and Johnny loves sitting next to Susie, and Susie wants it, and we get off. And I don't want to, we certainly want to have an opportunity to rapport and to dialogue, but there's really important, essential information you always need to be communicating, which is this better, worse, or same. Like sometimes it's that simple. Is your child doing better? Are they doing worse? Or are things the same? Because that helps the clinician who's prescribing. If things are pretty much the same, it may not be we're on the wrong medication. We might be on too little. The dosage may not be effective. If things are much worse and we're marching through these escalating doses, something's wrong. We need to change our course. If things are better, they're better. We don't always have to. If it's a boring medication follow-up visit, great. That means we did a good job. We can talk about other things.
My son takes 1 pill a day, and his pediatrician will not give you the 7th month until you have blood work.
Okay. Well,
which is good. And everybody else I know that has kids say, what's that for? So apparently not all of them do that.
How much time do I have? 2 minutes?
Well, I would suggest that you finish up what you want to say.
Okay.
We're going to have a few minutes to ask questions.
Okay. This slide is a really important one, so I'm glad this one came up next, which has to do with the child's perception of the medication. Like we're talking here, and we're all talking about the child whose medication is being prescribed for them. So some kids are very verbal about it and can really tell you about the medication and how it makes them feel and what it's doing to them. Other kids cannot, and sometimes we need to be the sleuths and investigators and figure things out. And then sometimes kids are actually telling us, but we're not listening well. And I've had kids say all of these things to me. My brain is not so scrambled. I mean, what a perfect explanation of what the medication is doing to that child. Now, that doesn't mean you needle them and say, no, Billy, tell me, how do you really feel? Like that, that's not how we approach it. And we're very developmental. So younger children, we may not mention it at all. We call it a brain vitamin, and that's that. If they have questions, we answer them. If they don't, we don't. I generally don't go through side effects with a child or even a teenager because they'll get them. You mention it, they'll get it. If they ask and they're agitated and they're nervous because they think all of a sudden now they're insomniacs, we say, it's okay, it's going to get better. We don't not address the issue, but I tend not to spend too much time on side effects with kids. Any questions? Yes.
Wait, before you go
Yeah.
to questions, I want to thank Dr. Ramos for her great talk. And I want to tell you that there's going to be coffee out here in the next 5 or 10 minutes. Judith is going to, if you don't mind staying
I'll
and
stay.
answering
Yeah, sure,
questions,
sure,
I'm going to have you
absolutely.
move to the front here. We're going to take your
Okay.
your presentation down so the
Okay.
next presenter can get ready. So feel free to go to the restroom now, have a cup of coffee, or stay and ask some questions. Your choice.
Read the inspirational quotes before you go.